Welcome to the Rad Onc Smart Review Head and Neck Cancer series. Today we are really getting into the weeds, doing a highly focused review of the technical foundation you need to treat post-operative oral cavity cancer.
Exactly. We're moving past just the guidelines and talking about the actual mechanics. This whole conversation is really for you, the resident, to build that technical vocabulary, to get the planning philosophy, and to translate some really complex surgical pathology like extranodal extension directly into a treatment plan that's both compliant and, curative.
Our mission today is super specific. We're focusing on the fundamentals that define a competent radiation oncologist.
Right.
We're talking simulation setup, the whole philosophy behind GTV, CTV, and PTV, the nodal anatomy you have to know from the Gregoire Atlas, and, so critically, that rigid OAR constraint hierarchy.
Right. So by the time we're done here, you should be able to just reel off a board-ready 30-second summary for any post-op oral cavity case they could possibly throw at you.
Let's ground this right away. Let's put it into a clinical case because I think that makes it so much more real.
Sounds good. This patient is a perfect example of the kind of high-risk scenario we see all the time.
Okay, let's unpack it.
So we're looking at a 58-year-old man. He came in with a right lateral oral tongue squamous cell carcinoma. Clinically, this was a pretty big tumor, 11 millimeters depth of invasion, which makes it a T3 primary. His initial workup was N0.
Okay.
So the surgeon went ahead with a partial glossectomy and a right selective neck dissection covering levels 1 through 3.
And then that final pathology report hits your desk.
Yeah.
What are the findings that immediately scream post-operative radiation?
The path came back as a pathologic T3 pathologic N1. So we found one positive node out of 18 located in level 2. And here's the kicker. That positive node had extranodal extension, or ENE.
Wow.
The margins were negative, but, they were tight, 5 millimeters.
Okay, so we have the trifecta of badness, really. We have the T3 size, we have confirmed nodal disease N1, and then the absolute primary driver for intensifying treatment, the ENE. The surgeon says you have to radiate. But with ENE, this decision gets elevated immediately. This patient needs post-operative chemoradiation.
Exactly. And that's not a preference thing. It's based on just overwhelming phase 3 evidence. I mean, we're talking about RTBG 9501 and EORTC 22931.
And landmark trials.
The landmark trials, they showed very clearly that for patients with these high-risk features, specifically positive margins, or ENE adding concurrent platinum-based chemo, gives a significant boost to overall survival and regional control compared to just radiation by itself.
Let's drill down on ENE for a second. Why is it such a dominant, such a powerful driver in our decision-making?
Well, ENE means the tumor has literally broken through the lymph node capsule and is now invading the soft tissue around it.
So it's not contained anymore.
It's not contained. And that dramatically increases the risk of both local recurrence and distant mets. RTOG 9501 is showed that for patients with ENE, the absolute survival benefit of adding chemo was huge. It proved that radiation alone just isn't enough to sterilize that aggressive pattern of spread.
Yeah.
So that evidence makes chemoradiation a complete non-negotiable here.
That sets the stage perfectly. Now let's get technical. First challenge for you on an oral board or just with an attending. Describe the simulation setup. You need to be able to deliver this flawlessly.
I'm ready.
Okay, give us the full canned, board-ready summary for this patient's simulation.
I would simulate this patient supine in a 5-point thermoplastic mask with the neck extended and shoulders pulled down. I'd use a bite block to displace the tongue from the hard palate. CT simulation with IV contrast at 2 millimeter slice thickness from vertex to below the clavicles. I would fuse with a preoperative MRI to identify the original tumor extent for CTV delineation.
Perfect. That is the recitation that gets the checkbox. Now let's break down the why for every single element, because that's where the examiner is going next. They want the clinical justification.
Let's do it. So, starting with positioning. We simulate the patient supine with the neck extended. This neck extension is just. It's fundamental for all head and neck planning. We're trying to get as much physical separation as we can between the tumor target and the spinal cord, which is our #1 organ at risk.
And for oral cavity specifically, extending the neck has another big benefit, right?
It does. It opens up the submandibular space. This makes it so much easier to get good, uniform dose coverage to all of level 1B, the submandibular triangles, which are critical targets for oral cavity primaries. And it does that while helping minimize dose to things like the larynx below.
Okay, next up, the 5-point thermoplastic mask. It grabs the head, face, and the shoulders. Why do we go for a 5-point over a 3-point, especially when the main tumor is up in the tongue?
The number one reason is reproducibility and stability of the inferior field edge.
Ah, the low neck.
Exactly. Even though the tongue is high, we're treating the neck down to level 3, and in this case with N1 and ENE, probably level 4. A 5-point mask that locks down the shoulders makes sure that the bottom of our PTV stays consistent day after day. It prevents those daily shifts in the low neck that could mean you miss the target or you're needlessly irradiating the top of the lungs.
Makes sense. Okay, accessory devices. The shoulder pull down. You have to have one. Why is this so vital?
It's pure geometry. The patient just grabs a strap and pulls their shoulders down. This pulls them out of the lateral beam path.
So the beans have a clear shot.
A clear shot.
Yeah.
If you're treating levels 3 and 4, the shoulders are almost always in the way. By pulling them down, you get this nice, clear, low attenuation path for your lateral beams. That means better dose uniformity, less need for tricky anterior fields, and you don't end up with a cold spot right where you need dose in the low neck.
Right. And what about the bite block or dental stent? This is a really functional piece of equipment.
It has a crucial dual role. Role 1. It physically pushes the tongue away from the hard palate and the maxilla, so it displaces uninvolved oral mucosa right out of the high-dose region.
Getting healthy tissue out of the way.
Exactly. And role 2, by creating that air gap between the tongue and the palate, it increases separation. And that separation is what spares the normal tissue on the uninvolved side. It makes a huge difference in mitigating acute mucositis and long-term xerostomia. We're basically using physics to protect tissue we don't want to treat.
Love it. Okay, for imaging, you specified CT SIM with IV contrast at 2mm slice thickness from vertex to below the clavicles. Break that down for us.
IV contrast is mandatory, full stop. For nodal disease, for contouring, you have to have it. Without contrast, you cannot reliably tell a blood vessel from a lymph node, especially after surgery when all the anatomy is distorted.
Okay, and the 2mm slices.
2mm slice thickness just gives us the high fidelity we need for accurately contouring small things, like cranial nerves, retropharyngeal nodes, and the precise boundaries of our PTV.
And the scan length vertex to below the clavicles. Why so long?
We need the skull base, the vertex to see the top of level 2 and the retropharyngeal nodes. And we need to go down to the thoracic inlet, which is below the clavicles, to make sure we've covered all of level 4 and, if we need it, level 5. Cutting the skin short of the chin or something. That's a fundamental error.
And the last piece of this puzzle for a post-op case, MRI fusion.
Yep.
You said this is mandatory, especially for oral cavity.
Oh, it is absolutely non-negotiable. The post-op CT scan, it just shows a surgical bed. It's filled with scar tissue, clips, maybe a flap. The anatomy is a mess. The preoperative MRI is our ground truth. It's the gold standard for showing the original three-dimensional shape and size of the tumor.
So you're contouring where the tumor was, not just where the scar is.
Precisely. We have to define our high-risk CTV based on where the tumor was, so we have to fuse that pre-op MRI to the planning CT to locate it accurately. If you skip the MRI fusion, you're basically just guessing where your highest dose should go. You're introducing massive uncertainty.
That is the perfect transition into volume philosophy and margins. This is really where postoperative radiation takes a sharp turn away from definitive radiation.
It really is. And we have to be so clear on the framework here. The GTV, CTV, and PTV distinction.
Okay, let's start with GTV.
GTV, gross tumor volume, is defined as disease you can see or feel. So since the surgeon took the tumor out, in a post-op case with negative margins like this one, there is typically no GTV. Our whole focus shifts to defining where the microscopic disease might still be lurking, and that's the CTV.
And here it is. This is the core clinical pearl that trips up so many trainees. Postoperative CTV margins are totally different from definitive margins.
They're completely different. For a definitive case, you might do a 5 to 10 millimeter expansion around your GTV standard. But for the postoperative surgical bed, we are routinely expanding by 10 to 15 millimeters, 1 to 1.5 centimeters.
Let's go back to that analogy you used, because it's so good for remembering why. Why does the surgeon's work demand such a bigger buffer zone from us?
The analogy is like comparing painting surfaces. So defining margins in a definitive setting, that's like painting on a flat, dry board. The cancer is there, it's localized, the tissue planes are intact, and microscopic spread is, well, it's pretty predictable. A small margin works.
But after the surgeon's been in there,
The surgical bed is like painting on a wet, uneven canvas. The surgery disrupts everything. Tissue planes are gone, vessels are clipped, nerves get pulled around, scar tissue forms, and all of that disruption can scatter any leftover microscopic disease in totally unpredictable ways.
I see.
So because of that surgical uncertainty, we need a much bigger, more robust buffer zone, that 10 to 15 millimeters, to make sure we're compensating for that disruption and covering all that potential residual disease.
That really makes it stick.
Yeah.
So practically, how do we define the high-risk CTV around that surgical bed?
We use established guidelines, like the ones from Evans and Beasley. The technical method is to take the preoperative GTV plus a 1 centimeter expansion, which we find using our MRI fusion, and then we do a Boolean combination of that volume with the visible postoperative surgical bed plus a 0.5 to 1 centimeter expansion around the clips or the resection cavity. It's a comprehensive approach that covers both the original tumor site and the whole area messed up by the surgery.
We said it before, but it's worth saying again. You have to follow that up with rigorous anatomic editing. Just blind expansion is not okay.
Oh, it's malpractice. The CTV has to respect natural anatomical barriers that the tumor never crossed. The classic example in the oral cavity is the mandible. If your pre-op imaging showed no cortical invasion, no marrow invasion, then your CTV should be edited so it does not extend into the mandibular marrow.
Because irradiating healthy marrow just increases ORN risk for no benefit.
For zero gain in tumor control, you contour right up to the periosteum, the surface of the bone, and you stop there.
So our patient is high-risk T, 3N1 with E&E. So we're going to use a risk-tiered CTV approach. Some people call it dose painting. Let's define the 3 tiers and their doses.
Okay, so the high-risk CTV. This is the area of highest concern. The surgical bed itself, the spot where the E&E was, or any area with positive margins. This volume gets the highest dose, 60 to 66 gray.
And the intermediate risk CTV.
This covers a broader area. Typically, the entire surrounding surgical bed, the involved nodal levels that were dissected but didn't have E&E, or maybe areas with high-grade features like extensive PNI. This tier gets a slightly lower dose, 54 to 60 gray.
And what's the clinical thinking behind that 54 to 60 gray dose? Why not just 54?
We use that dose to sterilize established but subclinical disease. 54 gray is generally what we think is needed to kill microscopic disease burdens up to about 5 millimeters. Since this area is right next to the primary site, we assume there's a slightly higher burden of microscopic risk there than in the distant elective nodes, so that justifies bumping the dose up a bit from the elective tier.
Got it. And finally, the low risk or elective CTV.
This covers the uninvolved nodal levels that we still consider at risk based on where the primary tumor was and its known drainage patterns. This volume gets the true elective dose, 50 to 54 gray. The goal here is just sterilizing any occult disease, which we assume is less than a millimeter in size.
Okay, let's move to the last geometric volume, PTV, the planning target volume. This is all about accounting for setup, uncertainty, and motion.
Right, the PTV is critical because no setup is ever perfect and patients, they move. With daily image guidance like a cone beam CT, the standard isotropic margin for head neck is usually 3 to 5 millimeters.
So you mentioned a specific clinical pearl for oral cavity cases about PTV margins. Why will we think about an asymmetric PTV up in the oral cavity?
It's because of the high likelihood of daily chin tilt variability. Even when they're locked in a 5-point mask, small movements in the patient's pitch and yaw can cause a pretty significant non-isotropic movement of the tongue and oral cavity relative to the hard palate. The movement is often largest in that superior-inferior direction.
So to guarantee coverage despite that variable movement,
We compensate by adding a little extra margin superiorly. So we might use a 7 to 8 millimeter margin just in the superior direction while keeping 5 millimeters everywhere else. And showing you understand that nuance, that really demonstrates to a board examiner that you get the practical day-to-day challenges of treating the oral cavity specifically.
that's great. That covers volumes. Let's dive deep into nodal coverage and anatomy. This is where the board exams can get merciless.
Yeah, the first step, the non-negotiable step, is to know the reference standard, the Gregoire Atlas, specifically the 2013 Radiotherapy and Oncology Consensus Guidelines. You just have to know the boundaries of nodal levels 1 through 5 and the retropharyngeal nodes, cold.
Okay, let's spend a minute on some of those critical boundaries, starting with the highest risk area for oral cavity, level 1.
So level 1 is divided into 1A, the submental, and 1B, the submandibular, key boundaries. Superiorly, it's the mandible, inferiorly, the hyoid bone. posteriorly the back edge of the submandibular gland, and anteriorly the midline. Level 1B, which is the main drainage for the lateral tongue, is bounded medially by the anterior belly of the digastric. You have to be able to see that space in your mind.
And level 2, where our patient's positive node was, this is divided into 2A and 2B.
Right. Level 2 runs from the skull base all the way down to the cricoid cartilage, where it transitions to level 3. It's defined posteriorly by the sternocleidomastoid muscle, the SCM, and the 2A to B split is really important. 2A has the jugular nodes that are anterior to the internal jugular vein, the IJV, that's the primary drainage. 2B has the nodes behind the IJV, which we can sometimes spare in lower risk cases.
How about the more distant but still important nodes, level 5 and the retropharyngeal nodes?
Level 5 is the posterior triangle, so that's the space between the back of the SCM and the trapezius muscle. We usually only treat level 5 if there's really extensive disease, and level 4, maybe level 2B. The retropharyngeal nodes are medial to the carotid sheath, way up high, up to the skull base. For oral cavity tumors, especially the ones near the back of the tongue, these nodes are often electively included, and they are notoriously hard to see without IV contrast and thin CT slices.
So with that anatomy lockdown, let's talk drainage patterns. Our case, oral tongue.
Oral tongue primarily drains to levels 1, 2, and 3, but the crucial biological curveball here is the up to 15% risk of skip metastasis.
Meaning the cancer can jump over level 2 and go straight to 3 or even 4.
Exactly. It bypasses the first station. Which brings us right to that board favorite, the level 4 question. The old teaching was just always include level 4 for oral tongue. How do we give a more nuanced modern answer?
You have to show your thinking with a risk-based rationale. The decision to include level 4 is really driven by tumor burden and aggressive biology.
So let's define when level 4 can be omitted.
Okay, if your patient is clinical N0, has a well-lateralized tumor, and, this is key, has had an adequate neck dissection, which some define as at least 18 nodes examined, and the path comes back pathologic N0, then the risk of an isolated level 4 recurrence is tiny, under 3%. In that very specific low-risk situation, leaving out level 4 is defensible. The toxicity you spare, especially swallowing, outweighs that minimal risk.
And when is level 4 appropriate or required, like in our case?
Well, it's appropriate anytime there is positive nodal disease, like our N1 patient, especially if that disease is already down in level 3. And given the high tumor burden and that aggressive ENE in level 2 in our case, covering level 4 is just prudent. You're covering for potential skip mets or just inferior spread.
So the comprehensive defensible board answer for level 4 coverage should sound something like this.
I would include level 4 for oral tongue primaries, particularly with nodal disease or level 3 involvement, given the risk of skip metastases. For pathologic N0 necks after adequate dissection, level 4 may be omitted with close surveillance.
Perfect. Now the last anatomical decision point, ipsilateral versus bilateral coverage.
The classic rule of thumb still holds pretty well. Treat the bilateral neck if the primary is within 1 centimeter of the midline. But there's a longer list of aggressive features we should think about.
What are the things that would really push you towards bilateral treatment, even if it's not right on the midline?
Any subsite that naturally crosses the midline, like the ventral tongue or floor of mouth, bulky nodal disease, N2 or N3, the presence of ENE, because it just suggests a higher chance of occult contralateral spread. Tumors with extensive PNI or LVI also tip the scales toward bilateral.
Our current case rate lateral tongue, N1, ENE, it's right on that borderline. It's well lateralized, which argues for IPSI, but the ENE is an aggressive feature.
It is. But since the tumor is well lateralized, the risk of contralateral spread is probably still low enough that we can watch it closely, and that allows us to spare the contralateral OARs, especially the parotid gland. The things that support keeping it strictly ipsilateral are a well-lateralized primary more than 1 centimeter from midline and limited contained nodal disease. You always want to try to spare that uninvolved parotid if you can justify it.
Okay, let's tie this all together in the clinical decision-making and treatment algorithm. This is the if-then ladder for dose and chemo.
This is where pathology meets physics.
Let's do scenario 1. Low risk, so negative margins and no ENE.
If you have negative margins and no ENE, you're looking at postoperative radiation therapy or PORT alone. The surgical bed CTV gets 60 gray, and the elective nodes get 50 to 54 gray. That's enough to control microscopic disease for lower risk cases without all the toxicity of chemo.
And scenario 2, high risk adverse features, our current case with ENE.
Right. If the pathology shows ENE or positive margins, you have to intensify treatment. You escalate the high-risk CTV dose to 63 to 66 gray, and you add concurrent platinum-based chemotherapy. Like we said, R2G 9501 basically mandates that intensification.
Let's talk fractionation, because pretty much everyone uses the SIB technique now.
The canned speech for dose, 60 to 66 gray to the high-risk KTV in 30 to 33 fractions using SIB, 50 to 54 gray to the elective nodal volume simultaneously.
So that translates to 2 grays per fraction to high risk, and usually something like 1.6 to 1.8 gray per fraction to the elective areas. SIB lets us treat all the risk levels at the same time, which shortens the overall treatment time and theoretically might have a better biological effect.
Okay, we need a mnemonic for those major adverse features that force you to escalate. E and positive margins are the big two, but what else is on that list?
We often list positive margins, extranodal extension, lymphovascular invasion, LVI, and perineural invasion, PNI. PNI and LVI, they mean the tumor cells are traveling along nerves or blood vessels, which suggests they're more likely to spread.
That list, E11B, is a bit dense for quick recall. Since E and positive margins are the real triggers for adding chemo, let's focus on those two for a quick hit mnemonic.
I agree. The things that just completely change the paradigm are ENE and positive margins. Let's use something simple. Escalate margins ENE, or EME. If you see EME, you escalate the dose and you add the chemo.
I like it. EME. This brings us to maybe the most complex part of planning, the OAR hierarchy and constraints. You just can't be a successful clinician if you compromise safety or efficacy for convenience.
So this hierarchy is rigid. You have to memorize it and you have to internalize it.
Let's start with Tier 1, non-negotiable absolute constraints. Safety first.
The absolute #1 priority is the central nervous system. The spinal cord maximum dose must be under 45 gray. The brainstem maximum dose must be under 54 gray. And if meeting those constraints means you have to underdose your CTV a little, you either compromise the coverage minimally, or even better, you change your whole technique until the constraint is met. You never, ever knowingly exceed those limits.
What about the spinal cord PRV, the planning organ at risk volume?
The PRV is usually a 3 to 5 millimeter expansion around the actual cord, and we aim to keep the max dose to that PRV under 50 grays. That gives you a buffer so you know the actual cord dose is staying well below that hard limit of 45 gray. If your PRV is consistently getting hotter than 50, your neck probably isn't extended enough, or your posterior CTV is too big.
Okay. Tier 2, target coverage. Efficacy comes right after safety.
Right. If you can't cure the patient, nothing else matters. The high-risk CTV has to be covered. The standard requirement is that D99, the dose covering 99% of the volume, should be at least 100% of your prescription dose. The rule is simple. Cover the tumor first, then you can worry about quality of life.
And now, Tier 3, xerostomia prevention, quality of life. This is where most of the planning trade-offs happen.
And this all revolves around the parotid glands. If we're treating the neck bilaterally, the goal is to keep the contralateral parotid mean dose under 26 gray.
Why that exact number, 26 gray? Let's talk about the QuantTech data that backs that up.
The QuantTech data showed this really clear dose-response curve between the mean parotid dose and the risk of severe xerostomia. At a mean dose of 26 gray, the risk of severe salivary distension is manageable. It's around 20%. But if that mean dose creeps up towards 40 grays, the risk just skyrockets to 50%. So that 26 gray goal is our most reliable threshold for keeping enough long-term parotid function.
What about the submandibular glands? We can't forget them. They drive our resting saliva.
Oh, absolutely crucial. They contribute about 65% of resting flow. We try to keep the contralateral submandibular mean under 39 gray. They're more sensitive than the parotids, but that threshold allows for some reasonable recovery over time. And of course, if you're treating unilaterally, you should be able to keep the uninvolved salivary glands under 10 gray mean, which basically guarantees they'll work fine.
And the broader oral cavity itself.
The overall oral cavity mean dose, which covers all those minor salivary glands in the palate and lips and cheeks, should be kept under 40 gray. That helps with patient-reported chronic dry mouth and cuts down on secondary problems like fungal infections.
All right, here's the challenge question. If meeting that 26 gray contralateral parotid constraint means you're underdosing the posterior inferior edge of level 3x3 gray, which one do you break?
That is a classic board dilemma. The parotid constraint is Tier 3, quality of life. The CTV coverage is Tier 2, efficacy. Tier 2 wins. Every time. You have to maintain your CTV coverage, even if it means you blow through the contralateral parotid mean and you accept a higher risk of xerostomia. We can manage dry mouth. We cannot fix a geographic miss that leads to a recurrence.
Good answer. On to Tier 4. Swallowing structures, function preservation, especially protecting against aspiration.
Yeah, swallowing function relies heavily on the pharyngeal constrictor muscles, which are often right in our CTV. We focus on the mean dose to the superior and middle constrictors, and we aim to keep it under 50 gray. The data shows that below 50 gray mean the rate of symptomatic dysphagia and aspiration is significantly lower, around 20%. If you push that mean dose above 60 gray, you see a strong correlation with chronic, severe swallowing problems.
And what about the larynx?
We keep a close eye on the supraglottic larynx and the glottic structures. We aim to keep the mean dose to those under 40 gray for bilateral treatments. If we can keep that dose down, the patient has a much better shot at maintaining a functional swallow and vocal quality. The inferior constrictors and the cervical esophagus also need protection, aiming for a mean under 35 Dern. For gray is a good idea, especially in bilateral cases.
Finally, Tier 5, the mandible. This is all about preventing osteoradionecrosis, or ORN, and this is so tough in oral cavity planning where your target is right up against the bone.
Mandible planning is a balancing act. We have two main goals. First, geometrically, you have to avoid hotspots. The max dose outside the PTV has to be under 100% and inside at or below 105%. Second, volumetrically, you want to minimize the volume of bone getting a high dose.
What are the key volume thresholds we're looking at?
Institutions vary, but we look very closely at V50, V60, and V70. The V70, so the volume getting 70 gray, should ideally be under 5% of the mandible volume, and the absolute max dose to any uninvolved part of the mandible should be kept under 72 gray.
What's the classic planning mistake here?
It's that trade-off we just talked about. The classic mistake is prioritizing Tier 5, sparing the mandible, over Tier 2, covering the target. If the tumor bed is right on the bone, you have to cover it, even if it means accepting a higher V70. The error is when a dosimetrist pulls dose off the surgical bed to meet the mandible constraint, or even worse, they move the hotspot out of the CTV and into an uninvolved piece of bone just to meet some QOL goal somewhere else.
Always check where your Dmax is. If the hotspot isn't in the CTV, it is almost certainly a planning error.
Exactly. If the plan forces you to accept a high dose to the mandible right next to the tumor, you counsel the patient about the ORN risk. You do not compromise the dose to the target.
We've covered the whole framework. Let's synthesize this into some high-yield review, starting with the 3 most common planning traps residents fall into.
Okay, trap 1. Applying those small, definitive margins, like 5 millimeters, to a post-operative case.
And the correction is, post-op CTV margins have to be large, 10 to 15 millimeters on the surgical bed to account for that tissue disruption. And always use your pre-op MRI fusion.
Trap 2. Making level 4 coverage mandatory for all oral cavity cases.
Right. The correction. Level 4 coverage is risk-based, not automatic. It's essential if there's nodal disease, especially in level 3, but you can omit it for low-risk, path N0, well-lateralized cases after an adequate dissection.
And trap 3, prioritizing quality of life structures, like the parotids or the mandible over spinal cord safety or target coverage.
The correction. Know your hierarchy. Cord max under 45 gray, then target coverage, D99 at 100%, and then quality of life. Never flip that order.
All right, let's hit the clinical pearls. These are the must-know nuances that show you really get it.
Pearl 1. Post-operative CTV margins are larger than definitive. 10 to 15 millimeters on the surgical bed. Just remember that analogy. Painting on a wet, uneven canvas.
Pearl 2. The bite block has a dual purpose. It displaces uninvolved mucosa, and it creates separation to protect the contralateral oral cavity.
Pearl 3. MRI fusion with the CT is absolutely mandatory for post-op oral cavity planning so you can accurately define where the tumor was originally.
Pearl 4. The OAR hierarchy is non-negotiable. Cord, then target, then salivary glands.
Pearl 5. That contralateral parotid mean dose under 26 gray. That's the quant-tech threshold that keeps the risk of severe xerostomia down around 20%.
And Pearl 6. Level 4 coverage is dictated by risk, specifically nodal status and the primary site biology, remembering that oral tongue has that higher skip risk.
Let's lock this in. Rapid-fire board review segment. Question 1.
A 62-year-old woman is being planned for post-operative radiation to the right oral tongue. What is the most appropriate CTV margin on the surgical bed? Is it A, 3 to 5 millimeters, B, 5 to 7 millimeters, C, 10 to 15 millimeters, or D, 20 millimeters?
The answer has to be C, 10 to 15 millimeters. The rationale is that postoperative CTV margins need to be expanded significantly because of all that surgical disruption and uncertainty.
Question 2. You're planning a postoperative oral cavity case. Which of the following is the correct OAR priority hierarchy when you're optimizing an IMR2 plan? A, parotid mean, then target, then chord. B, spinal cord max, then parotid mean, then target. C, target, then chord, then parotid. Or D, spinal cord max, then target coverage, then parotid mean.
The answer is D, spinal cord max, then target coverage, then parotid mean. Rationale. Safety, which is the chord, is first. Efficacy, tumor control, is second. And quality of life, the parotids, is third.
Question 3. A patient with a PT2N0 buccal mucosa cancer, 0 of 22 nodes, no adverse features, undergoes port. Which nodal levels require elective radiation? A, no nodal radiation needed. B, ipsilateral levels 1B through 3. C, ipsilateral levels 1D through 4. Or D, bilateral levels 1B through 4.
This is a great one. The answer is A, no nodal radiation needed. Rationale. For a pathologic N0 neck after an adequate dissection, and that's 22 nodes, with no adverse features, adding port to the neck is just unnecessary toxicity with very little expected benefit.
Okay, last one, rapid fire, integrating our case. Our patient had that well-lateralized right oral tongue tumor. If that primary tumor had crossed the midline by just 2 millimeters, what 3 significant changes would you make to the plan?
Okay, 3 changes. 1, I would definitively add contralateral neck coverage. I'd include elective levels 1B through 3 bilaterally because the risk of contralateral mess just skyrockets once you cross that midline. 2, I would probably escalate the dose to the midline primary region as an intermediate risk CTV, maybe to 60 gray, because of the high chance of microscopic disease still in the midline. 3, I would have to seriously reevaluate the contralateral OAR goals, specifically the parotid mean, trying to treat bilateral levels 1 through 3. Meeting that 26 gray constraint would become extremely hard, probably impossible.
That is a perfect demonstration of clinical integration.
So let's do a final summary of all the major take-homes from this whole review of simulation and volume fundamentals.
Okay, simulation. Remember the details. Supine, 5-point mask, neck extension, shoulder pull-down, and a bite block. IV contrast and thin slices are mandatory, and always use MRI fusion for post-op cases.
Volumes. The big teaching point is the large margin. Post-op CTV margin of 10 to 15 millimeters on the surgical bed. PTV is 5 millimeters standard, but remember that asymmetric margin, maybe 7 to 8 millimeters superiorly, to account for that chin tilt variability in the oral cavity.
Nodal coverage. Know your Gregoire atlas, especially level 1 and 2. Oral tongue drains to 1 through 3. And level 4 coverage is risk-based. You need it for nodal disease, but you can skip it for low-risk path N0 cases.
And OARs. The hierarchy is rigid, spinal cord max under 45 gray, then target coverage priority and that crucial QOL constraint. Contralateral parotid mean under 26 gray. Never sacrifice safety or efficacy for QOL.
We've laid out all the planning principles for this really complex subsite, but let me leave you with one final advanced thought that often tests the limits of what we do. Imagine our patient needed a segmental resection of their mandible and now has a mandibular reconstruction with titanium metal hardware right near the surgical bed.
Oof. That metal just introduces huge uncertainties. Beam hardening dose calculation algorithms go haywire.
Precisely. The planning system's dose calculation right near that metal is highly suspect. So how does that artifact impact your volumes and, more importantly, your OAR goals for the mandible right next to it? You've got 2 terrible options. Option A. You trust the dose calculation, risking an uncontrolled hotspot that leads to a high ORN risk. Or option B, you increase your PTV margin around the metal to deliberately pull the prescribed dose off the titanium, accepting that your dose calculation is probably inaccurate, but maybe preserving the adjacent bone. It's a classic dilemma, accepting higher ORN risk versus the profound uncertainty of dose calculation near metal. And that's a tough trade-off you will absolutely face.
A perfect encapsulation of the complexity we deal with in advanced head neck planning. Complete practice oral boards at radonsmartlearn.com and subscribe to Radon Smart Review for our next deep dive. Thanks for tuning in.